has been obsessed with vaccines for the past year. But prior to that, most of us probably thought of them as something that only toddlers had, and maybe old people if they needed to avoid getting the flu. This past year, of course, has changed that. And for the next hour, we are going to be considering how vaccines have helped to protect the world and how they can continue to do so. I'm Sarah Montague. Normally you'll hear me at lunchtime on Radio 4, but I couldn't resist the invitation from my old university, Bristol, to dive into the history and the future of vaccines. They organised this event in partnership with Pfizer to mark the launch of the Centre of Excellence for Epidemiology of Vaccine Preventable Diseases. Quite a mouthful. It is the first centre of its kind in the UK, only the second in the world. And the plan for the next hour is that I've got a load of questions to ask of our panellists, but I'm also going to keep an eye out for your contributions. You can ask questions using the chat function. You'll find it on the, I think it's lower right-hand corner. You can just click on the chat bubble, send in some questions. They'll be fed through to me, and I'll keep an eye on them, and hopefully we'll get some of your questions answered. On social media, the hashtag is #VaccinesWork. But let me now introduce our panelists for the next hour. We have 4 leading experts in vaccine research and development. First off, Professor Adam Finn. He's Professor of Paediatrics at the University of Bristol and a member of the Joint Committee for Vaccination and Immunisation, the JCVI, which we've referred to many times because it advises the government on its approach to vaccines. Dr. Doug Brown is Chief Executive of the British Society for Immunology. Dr. Brad Gessner, Vice President and Global Medical Lead for pneumococcal vaccines at Pfizer, and Dr. Deborah King, who's Vaccines Research Lead at Wellcome. And I think we should probably start with a sense of the value of vaccines. And Dr. Brown, I think this is one for you. How would you sum up the value of vaccines when you compare them with other public health interventions?
Well, I mean, in 3 words, quite frankly, vaccines are great, and they are an absolute miracle of medical research and bringing medicines and interventions through to the general public. And if we look globally at the impact that vaccines are having, they come second in the list of positive impact on public health to providing clean water. And we can all appreciate the value of providing clean water across the world. Vaccines is number 2. You know, they save millions of lives every year, and it's not just about saving their lives, it's also about improving quality of life of people in low, middle, and in high income countries. So they're absolutely incredible, and you know, been around for many years, and I'm sure we'll come to it during the discussion, but very exciting to see how things have developed with the pandemic, and the future is looking, I think, very bright in terms of developing future vaccines.
Well, before we get onto that, I'm going to just stay with a bit more of the history. Deborah King, Dr. King, they've been around for what, more than 200 years, but they have changed a huge amount since cowpox was injected by Edward Jenner. When you look back over the sweep, what would you flag up as some of the most important moments in that history?
I mean, I think we have to mention first and foremost the millions of lives that are saved every year. The rollout of childhood vaccination programs across the world has had a massive impact in averting deaths and avoiding lifelong disability for millions and millions of children. And we've seen the impact of that over the last 40 years in almost every quarter of the world. I think considering seminal moments, though, I always consider the eradication of smallpox to be one of the most impressive achievements that vaccination has ever produced. But coming into more recent history, I think we have to acknowledge the speed of development of COVID vaccines as being phenomenal in terms of the scientific endeavour and also the rollout of vaccination. It's not just been the development of the vaccines, but the vaccination programmes that have been delivered by health services that we've seen really turn around our fight against COVID.
You've all, of course, made your career in vaccines. And I suppose at sometimes they might have felt a bit more like a backwater than they do now. But I wonder if there was a particular moment, Professor Finn, where you thought, look, this is what I want to do and why I want to be involved with vaccines.
Yes, as so often, it was a case of personal inspiration. I was very fortunate early in my career to land a job as a research and training fellow at the Children's Hospital in Philadelphia in a department that was run by Stanley Plotkin. He's still alive. He's still very active in his late 80s. He was the inventor of the rubella vaccine, the German measles vaccine, and has subsequently been involved in the development of several others. And the research that was going on in that department around vaccines, which we're actually now using, was certainly the source of inspiration to me, because I was already working in infectious diseases. And it became clear to me that given that we had the tools to prevent these diseases from occurring, that was going to be the much more potent approach to take rather than focusing on treatments, which of course are important too. But as Doug correctly says, the massive impact of vaccines dwarfs pretty much all of modern medicine put together. The one irony, though, is that this is an invisible success. And the reason that vaccines are a comparative backwater is that the people whose lives have been saved by these vaccines are blissfully unaware of it. There are countless millions of people alive today because of vaccines, and of course they receive vaccines, but they don't have the same narrative as, for example, a survivor of leukemia or of a serious infection. So we do need to work to enable people to understand that they themselves, many of them, are direct beneficiaries of these extraordinary tools. Tragically, I think we've lost Sarah. No, she's back. Or at least I hope she's back.
She hopefully will come back. I mean, just to build on what you were saying there, Adam, it's a bit unfortunate to... Sarah, are you back?
I've just come back. The joys of Wi-Fi. I was thinking, is this me? It was me. I think I heard much of what you said, Adam. Dr. Gessner, Brad, I suppose for somebody like me who isn't as immersed in it as you all, what would you say is sort of one of the more surprising things about vaccines and their history or the way they're used now that you think people don't really get or realize? I think you're going to need to unmute. My Wi-Fi, you're mute.
No. There we go. I didn't realize I was remuted after we joined. Can you hear me?
I can.
Okay, yeah. I mean, I think we could spend the whole hour on surprising things about vaccines, but yeah, I mean, I think one of the big things that I've spent a lot of time working on is the additional effects of vaccines that people don't realize. So everyone thinks about when they get a vaccine that they're protected, but many of the effects, and in some vaccines, the majority of the effects are not you directly being prevented from having an acute illness. It's you being prevented from having a direct illness, but because you no longer get the infection at all, you don't pass it on to other people. So, for example, one of the vaccines I first worked with was the main cause of pediatric meningitis called Hib. And if you start getting vaccine coverages at 20 to 30% in a population, it goes down for everybody because the germ just doesn't get transmitted very frequently. So that's one aspect. Other aspects that people don't recognize are all the downstream sequelae that occur because you never had the initial event. So, for example, if you're an adult and you don't get pneumonia, you may not get an exacerbation of your chronic lung disease, for example. And all of those things, when you start looking, are just massive, and they can even outweigh the direct effects. And, you know, the more I work with vaccines, the more I'm not entirely certain it's number two behind clean water. I think it may, in fact, even be number one as a public health intervention.
Good grief. Deborah, we're talking about the things that people don't think about, the advantages, and I suppose people do think of saving lives as the obvious one. What other indirect benefits would you add?
I think there are a whole host of...
Sorry, go ahead.
Sorry, Brad. Did you want to add something?
No, go ahead. I hadn't heard her say Deborah, but go ahead.
Okay. But I think there are well documented now much broader benefits from vaccinations, one of which is linking communities to health systems, providing regular contact with healthcare providers who can also support people in terms of their health through supporting education in health, providing support with social care, making that connection between health services and populations adds overall to the overall well-being of communities. But I think there are also huge economic benefits that are perhaps indirect benefits of vaccination. So they're considered to be one of the most cost-effective interventions. For every dollar that you spend on vaccines, apparently there is you get $54 back in terms of wider societal benefits. It also protects households from being pushed into poverty by the costs that are related to gaining access to healthcare in places where healthcare access isn't free. It improves educational outcomes and wider well-being in children because it allows children to stay in school. I think we've all seen the impact, if you have young children during COVID, of what sort of periods of lockdown and pulling children out of school has done to their educational attainment. And it also protects productivity in workforces by preventing days lost to illness. So you see a number of benefits overall that preventing illness in populations has that adds up to overall economic benefits. And I think the final thing I'd say as well is that we have a program of work, and I know a number of people are interested in the impact of using vaccines against tackling antimicrobial resistance, because if you can vaccinate people to prevent infections with bacterial pathogens, you reduce the need for using antibiotics, and then you drive down the selective pressure that drives antibiotic resistance. So it's another way of tackling what is a huge global health threat. Okay, now I'm a cynical journalist. I'm listening to you all singing the praises of vaccines in this sort of blanket way. And in a way, I thought of it when I read out the hashtag for the social media, hashtag vaccines work. It's got to be fair to say that not all vaccines work, or at least not all vaccines work on all people. And this, I mean, we're obviously going to come on to hesitancy, but I just want you to engage, if you wouldn't mind, on some of the occasions when things haven't worked as well as they should. I don't know who wants to kick us off on this. You know, I'm going to ask you not to be the cheerleader. Adam, I can see you. I think you're reaching for unmute. Go for it.
Well, I think the first thing to say is that there have been some disasters in immunisation. And I'm sure we're going to talk more about hesitancy later on, but one of the real challenges in the 19th century with Jenner's vaccine against smallpox was that there wasn't at the time a clear understanding of how to avoid contaminating the virus that was obtained from the cows and avoiding harming people by giving it to them. You may be interested to know, those of you that are French speakers, that the French have the saying, c'est la vache, which means it's the real deal. And what they used to do was bring the cow to the corner of the street in Paris so that the blisters could be broken and the inoculation done directly from the cow into the arm so that people could see that they were getting uncontaminated vaccine to avoid the risks of getting tetanus or other contaminations. And there have been further examples subsequently where things have not gone right. One of the very early batches of inactivated polio vaccine was inadequately inactivated and caused cases of polio, for example. So we've learned as we've gone along, and we should be completely clear that we've learned lessons from mistakes from time to time. It's not always been a completely clear cruise. And you're completely right that some vaccines work far better than others. And one of the things that we actually have to do all the time is to evaluate the relative effectiveness of vaccines to ensure that we're using the best possible versions and improving the ones that need to be improved. So it is a dynamic field. I'll just give a final example that we've been immunizing children against whooping cough, a great success story since the 1950s. but we still don't have adequate vaccines against whooping cough. Whooping cough still circulates in the United Kingdom. We still see cases, and we haven't solved that problem yet. We need better vaccines to get truly on top of the infection, get the indirect protection that Brad was telling us about. So yeah, it's not a story of perfection all along.
Well, Dr. Brown, what do you keep perhaps foremost in your mind when you're thinking, look, vaccines are great, they've done all these amazing things, but we've got to remember this before we become too hubristic about this?
No, absolutely. And I just to build on something that Adam just mentioned around 18th century vaccination techniques, I must say that I'm very pleased we've come a long way in improving those techniques, and that we're not lancing cowpox and injecting in the street. But in terms of how these vaccines work, you're absolutely right, and Adam's right that there are lots of things we can learn from in the past, but there are lots of things we still need to understand about the immune system as well, and how immune systems work in people, in particular as we get older. Because as we get older, our immune systems change, and the feeling is, and the evidence shows that perhaps older people respond less well to vaccination, actually at a point in their life, particularly where we take the pandemic into account, that actually vaccines could bring a lot of benefit to improving quality of life years. And so there's a lot that we can learn from ongoing vaccination programs. I believe we can improve on the vaccines we've already got. But the more that we can understand about our immune systems, the better we can work out, well, how can we manipulate them? How can we stimulate them to be in a position to protect us against these preventable diseases?
Okay. Well, let me move on to hesitancy, because I know the WHO describes vaccine hesitancy as one of the top 10 global health threats. Is it, do you think, partly because of the history? And Brad, Dr. Gessner, I don't know if you want to contribute on this. Do you think it's partly because of the things that have gone wrong in the past that people might be hesitant now?
Well, I'm going to go back to Adam's comment. I think it's actually the opposite. I think it's because things have gone so well in the past that people are hesitant. So when you look at measles vaccine and you don't see a case of measles and you've never met anybody that's ever had measles, you think, why should my kid get this? I mean, it's just a risk for them. Or if you think, I've never seen a case of HIV meningitis, I don't even know what meningitis is, because you've never met anyone who's had HIV meningitis. You know, it's a disease that was prevented right as I was finishing my pediatric residency. And we used to have kids come in all the time with HIV meningitis. And, you know, one kid died in 24 hours, came in, he looked pretty good. We diagnosed him, gave him antibiotics. I came back in the next morning and he was in the morgue. So those are the cases that don't occur anymore. So, you know, I have friends who are educated, you know, upper class people that have had all the benefits of society, and yet they are hesitant because they've never seen any of these diseases. And so they think, well, why do I need to put my child at risk? And I think the other thing just to point out is you had asked before about vaccines not always working for people. And I think it's important to recognize that vaccines are a social intervention. They're a public intervention. I would say more so than they are an individual intervention. And one of the reasons why everybody should be concerned about getting themselves vaccinated and their children vaccinated is to protect their neighbor who may not respond to the vaccine, the child with leukemia, the adult who's 90 years old, or whoever. So if the society is protected, it's going to protect those people who don't respond to vaccines.
Okay, Dr. King, what would you add on this question of hesitancy, what you think contributes?
I think it's really important in this one to just to be clear about what we mean about hesitancy, because I think hesitancy is sometimes a term that's used kind of interchangeably to address trust and confidence issues in vaccines. And I think has already been pointed out, you know, really there is a certain amount of complacency that we're not familiar with those diseases, vaccine preventable diseases anymore, and so people don't see the need. But I think hesitancy actually as a term, particularly in the WHO definition, it does actually cover a broad range of challenges, which can include practical issues that relate to people getting vaccines. And I think what we've seen through our own research is that one of the biggest barriers to immunisation and people taking up vaccines are practical access barriers. So, for example, where there are stockouts of vaccines, where there are travel restrictions and people can't attend vaccine centres, or it's inconvenient to get to vaccine centres. So putting together simple solutions that allow people to address access barriers, things like giving them timely reminders and easy access to booking systems and easy access to vaccine centres, can actually overall improve vaccine uptake. I think there's quite a lot that can be done in terms of addressing those practical barriers, which are not related to trust and confidence.
Is there something else there? We may not be taking the cow across the field so we can see what it is, but it's still a needle. And one sort of thinks, if it was a pill, people don't mind taking a pill, but the idea of you're injecting something in my arm or in my bum or wherever, I mean, it's a sort of, there's the ick factor. How important do you think that is, that sense of, don't inject that in me? Well, maybe I should ask Adam here, because Adam, you're a pediatrician, so you're having to deal with children and vaccinations.
Yeah, of course, kids don't like being jabbed, and their parents don't like their children being hurt. So I'm sure it plays a role. I think it actually, interestingly, also plays a role in healthcare workers who spend their lives sticking needles into other people, but are quite phobic about having needles stuck into themselves. So that's part of the story. Having said that, I think there's a cultural context to this, and Brad, who's worked in Africa, will I hope confirm that it's in some respects the opposite there. If you're not giving a drug in a needle, it's not really taken seriously as being potentially useful or effective. So I think there are complexities around that. But I would say that on this topic that there are some very interesting comparisons to be made with the levels of hesitancy we see, for example, across Europe, and they're widely different between countries. And we in the UK enjoy an extraordinarily high level of trust and engagement with our vaccine programs. And we do that, unlike our friends and colleagues in North America, without in any way compelling anyone to have any vaccine. Although the headlines in the last couple of days suggest that might change. But at the moment, that's the position. And I think that comes from many, many years of growth in public trust in the National Health Service. This is a massively valued service, and it's a massively trusted service. And the fact that the vaccines are delivered free at the point of care through general practice in general to people in their local communities engenders a vastly higher level of trust in the system. And I think that's being reflected in what we're seeing with the success of the current program in the UK. Okay, well, let's turn to what they're doing in the United States. In some states, and Brad, you might want to comment on this, which is the various inducements. I mean, there's lottery tickets, there's money, there's guns. I mean, is it something that is it working, or is it those sort of inducements to people?
Well, I think it's too early to say, but I mean, I think incentives are something that you have to really think carefully about, because not because they don't work, but because they do work. And you really have to be clear of what you're incentivizing. And so, if you're very clear that when you do X, it incentivizes Y, and Y is the good outcome, then they're worth doing. And just to comment on what Adam had said and your question, I mean, there are inducements that are really powerful in the U.S. So like infant immunization rates are lower in the U.S. than they are in the U.K., but school age immunization rates are high. And it's because we have school vaccination laws. So you don't have to get your kid vaccinated, but if you want them to go to a public school, they have to be vaccinated. So it turns out people are not so opposed to vaccines that they want to homeschool their children and not work. So when they get to be school age, they all get vaccinated. So that's an inducement that exists in, I think, every state. And so that's a really powerful one.
Well, I guess the possibility of travel may be the inducement in the UK that makes people vaccinate even their children. There's a question from the audience. Philip Kerr, What type of incentives should we be giving to encourage uptake? Better education, reference your thing, or financial rewards? How do you all feel? Doug, what are your thoughts on whether we should be inducing people?
Well, I think, I mean, as Adam said, and Debbie has alluded to, actually, we benefit from very high levels of confidence in vaccines in the UK. So it's questionable whether we should be introducing any inducements. I mean, what we found at the British Society for Immunology, working through our thousands of immunology members across the UK, is that the best way to convince people to go for vaccination, that's during the pandemic and pre-pandemic, is to have a conversation with them and to answer any questions or any concerns, engage on a level and listen and empathize with the questions and some anxieties that people have got, and do our best to answer those questions. I mean, pre-pandemic, and the pandemic has changed a lot, of course, pre-pandemic, the issues are, as Debbie said, that less about confidence and more about convenience of immunisation services and that complacency, as Brad said earlier, and you mentioned the vaccines are their backwater. Well, yes, I would say before pandemic, they're a victim of their own success in, pretty much wiping out a number of these diseases and eradicating smallpox, of course. And so if people haven't seen these diseases, will they want to take the train, 2 buses, and take their child to a vaccination clinic while they're working 2 jobs? These convenience issues will give barriers, and if people are complacent, they're not likely to go above and beyond. So I think in the UK we're in a fortunate position, and there's some examples across Europe where some of these inducements have been introduced, and even mandatory programs across the piece, where actually from the back of that you're getting a reduction in the level of confidence in vaccine programs, because people generally respond not particularly positively to being induced, coerced, encouraged to be vaccinated.
Well, there's another question from the audience, which I think is brilliant because I had been going to ask it anyway, from John Ray. Is there something about the huge private companies behind vaccines making profit on vaccines contributing to the hesitancy we see in adoption? And obviously, Brad, this isn't one for you, as you sit currently within Pfizer. So, Deborah, can I have your thoughts on that? Do you think there is a sort of suspicion that this is all about people making money and profiteering?
I think that it's certainly a perception, but I think I suppose one of the perhaps what's perhaps less hidden from the public is actually the enormous cost and the enormous risk that goes into developing vaccines. And I think again we've seen this miraculous turnaround with COVID of developing a vaccine in under 1 year, but that has required enormous investments and investment at risk by a number of companies, and not all of those vaccines have been successful. So I think there is, although there may be a perception that those who are the winners do stand to benefit financially from that, but it's an enormously risky endeavour, and I think there is a very high proportion of vaccine candidates that move through the clinical pipeline and fail, and there has to be a way of financing that. If we want to develop new vaccines, there has to be the money to support it.
Well, Brad, then, can I ask you, is there something that you think the pharma industry could be doing to tackle vaccine hesitancy and improve uptake? Is there something that you would think, look, this is what they should do?
Well, yeah, and I just wanted to make the comment that while currently there are no government vaccine manufacturers in the developed world, so there's more or less 100% reliance on pharma to mass manufacture vaccines. It's all done with government, right? So this isn't a widget that a company can make and then just start selling at Walmart. There's a whole regulatory process that's run by government agencies that makes sure that every step of the process has been done correctly. And at any step of that process, they can say, no, your vaccine is done. So all vaccines are public-private partnerships, even if the development is done even the development can be done, and a lot of the COVID vaccines were done in partnership with government in the US or in other places. But at the end of the day, it's all public-private partnerships in order to get the vaccines out. In terms of your question of vaccine hesitancy, I don't know that that's a pharma role. I think the pharma role is to develop the vaccines to the best standards that they can and in line with all the regulatory requirements in countries and ethical requirements. But I think vaccine hesitancy is more of a public health issue that's the responsibility of governments. I mean, I think pharma companies can help with that, and there's a lot of great scientists that work with pharma, but at the end of the day, delivering vaccines, improving uptake, I think is the responsibility of public health agencies.
Well, another question from someone in the audience I think for Dr. Brown, I'll give this one to you if you don't mind. Patricia Revel asks, what role do you think the media played in COVID vaccination hesitancy in particular? How could this have been handled better?
Yeah, it's a really good question. I mean, we would probably say actually the role of the media during the pandemic has been really responsible, and particularly focusing on the UK, a country we live in. The UK are listening to and the media are inviting scientists, academic clinicians, public health experts to give a view on what is happening. I actually think the approach that the UK has taken, and we can see in the data that actually uptake of the COVID vaccine is pretty high in the UK, which is to be celebrated. But where we are struggling is in particular communities, in particular parts of the country that need a different approach to that engagement. And we need to be working with local leaders, trusted leaders in the community, and also with health and social care workers, because they are the most trusted, and we've seen that from the evidence from surveys over many years. They are the most trusted people in the UK. So if we can empower our health and social care workforce to have conversations with the communities, we can work with local community leaders to get messages across and have conversations with their communities in a way that they know work. That can be really positive. But on the media, I mean, we work with immunologists across Europe, and speaking to a colleague in France, the French media are operating a very different way, whether it's right or wrong, we don't know, but not really engaging with the scientists and with immunologists. And there are particular struggles with some confidence in vaccines. So actually from a UK perspective, I'd possibly controversially say that the media have done a fantastic job and on the whole been very responsible.
Well, I find myself in a strange situation, because as I'm listening to you, I'm thinking that the BBC, there are some people in this country who think the BBC, that the media have been acting as cheerleaders for vaccines. So it's quite an interesting and delicate balance as to, you know, how much one gives airtime to those who are skeptical about their use. Professor Finn, do you have any thoughts on that?
Well, the one thing that's not come up yet, but I guess we have to talk about, is social media rather than the mainstream media. I engage with social media. I do tweets and have very substantially increased the number of followers on that social medium during the course of the pandemic because of the interest in vaccines, and that's what I tweet about. But what I've observed is that the tweets that excite a lot of interest and response are often the ones where people who really don't like what I've had to say get engaged and then start passing them around, and I get a big torrent of abuse. The ones that are sort of more interested to the scientists, you know, they just get some modest likes and comments and everyone agrees and nods, and that's all fine. So I think the social media landscape is a fascinating one, that not just in the field of vaccines, but in all sorts of other fields we're still getting to grips with, because it consists of these different tribes of people who all reinforce their own views. There's people like me who all agree with me, and then there's lots of other people who don't like what I say, but they all agree with each other. And of course, that's an international network, and it does influence it's really the source of information for many people now, rather than the BBC. So I think that's an area for vaccinologists like me, but obviously for other areas too, that we need to understand and try and find ways to ensure that we use these things creatively, and also find ways to give people good quality information that can perhaps influence what their decision-making, what their decisions are.
Dr. King, I mean, it's not impossible that something could be thrown up by these COVID vaccines. They don't have a long-term safety record. And if that happened, I mean, it's already happened to a small extent with the AstraZeneca and clotting, that could have a profound effect on trust in all vaccines, couldn't it?
I think it could, but I think as well that what we've been seeing with the rollout of COVID vaccines has been a really active engagement with safety, really active monitoring of safety events, and very clear communication about the level of risk. For example, the risk of clotting in younger people in receipt of the AstraZeneca vaccine was, I think, 1 in 250,000. So I think the risks have been quite clearly communicated, and having received my vaccine about a month ago, you're given a very clear kind of breakdown of what the risks are. So I think the risk communication has been very clear. And I think the messaging, the rollout of the COVID vaccination program has been, I think, very successful in highlighting to people what their relative risks benefits are in receiving those vaccines. But I think there's sort of the long-term approach. You're right that we don't know what the long-term effects are, but I do feel confident that we are taking the right approach in terms of monitoring and responding to those events as well. So, for example, the change in the recommendation for younger people to receive, to not receive the AstraZeneca vaccine based on the risk of clotting, I think has been made very rapidly, and I think people appreciate that rapid response. So we're seeing it's a rapidly changing environment, and I know that people who are making those decisions are having to respond to data very quickly, but I see that happening, and I would hope that that is reassuring for people in receipt of vaccines.
Adam Finn, you were talking about your social media. I can imagine that what you have seen thus far will be nothing as compared with what happens if you suggest that children should be given the vaccine. And that is the next imminent decision. I mean, I don't know which way it's going to go. You may do. You may want to share that with us, but I suspect not. There's a tremendous amount of pressure, and even today I interviewed Dominic Harrison, the public, who's in charge of public health in Blackburn, who's basically calling on the JCVI to stop dithering. Can you talk a little bit about the pressures of that, the challenges of making this decision when other countries have decided to vaccinate 12 to 18-year-olds?
Yes, I can talk in general terms. I mean, I think the JCVI so far in this pandemic has made good decisions, and the way it's been done is that it's not rushed forward. It's not dithered at all. What it has done is waited for the necessary evidence and then made well-informed judgments. Occasionally, we have extrapolated from the available evidence to make a slightly riskier judgment, for example, with the dose interval, which have subsequently, I'm glad to say, turned out to have been very wise decisions. But this is not a body that dithers to and fro. It's, on the contrary, it's a group that considers things very carefully and reaches very well discussed and well agreed decisions. And the current discussions, which you're right, I'm not going to go into here in this public forum, are just such an example of things being done carefully, cautiously, and in as fully informed a way as possible. What I can do, though, is wear my WHO hat, because I also work for the World Health Organization and chair the technical advisory group for the Euro region. And the WHO line on this is very clearly to bear in mind that a dose of vaccine given to a high-risk individual somewhere in the world, an elderly person, a person with comorbidity, is a much more valuable dose of vaccine than a dose of vaccine given to someone who's at extremely low risk, like a young child, who, although they may get infected, are almost invisibly unlikely to get seriously ill. So I do think whatever our domestic discussions may resolve, and you're right that that's ongoing, and I can't tell you what they will result in. All of us owe it to ourselves and to the world to think globally about this pandemic because an epidemic in India, for example, has recently had very direct effects, social, economic, and health, on this country. And that India is not the last time that that is going to happen. So we do need to continue to think globally about this.
Okay, just before we move on, because I want to get onto the global picture, as well as that, the effect on other vaccines and potential vaccines from what we've learned over the past year. Just a quick question. I don't know if any of you know, do we need to vaccinate teenagers in order to get herd immunity in the UK? Doug Brown, do you know?
So herd immunity for
COVID.
Go ahead.
Oh, no, Brad, if you want to.
No, I thought
I'll ask
you
you
said
both.
Brad,
How about
go
that?
ahead, Doug. No, Doug, go ahead.
So you mean?
I was going to say it's a UK question, not for me.
Yeah.
So.
I can ask a bit. I mean, the United States, Brad, have decided to go for it. Did they decide to go for it because for herd immunity you need to vaccinate teenagers?
Well, I think that that's part of the assumption. And I think that there are, part of the issue is just getting the vaccines distributed in ways that respect regulatory authorities and the standard process for getting vaccines out, as well as production. So obviously in the US, all the laws and availability and supply chains are all in place. So it's easy to get vaccines out to the next population. Versus getting them to India. So now there's the initiative by the Biden government to work with Pfizer to get, I think it's 500 million doses out. And so I think that'll relieve some of the need, but not obviously all of it. So that's where you need lots of companies producing vaccines that are effective and getting those to the countries that need. But anyway,
okay.
But the 12 to 18-year-old, in terms of the herd immunity, I think it's both direct protection, because in the U.S., when you look at that, if there is a substantial burden of disease, which is a relative judgment, then actually pharma companies are required to have a plan to vaccinate that population in children. And there's actually laws around doing trials and targeting children if there's a need for that. And there is disease in children. And I don't dispute Adam's argument. But it's that plus the indirect protection, and that the younger children may be a source of transmission. So I'll stop there.
Doug, that bought you a few minutes thinking time.
It did, didn't it? I should have used them more wisely. No. It's a tricky one. And as Adam has said, there are a lot of things that we need to be considering in the UK. And our initial goal really is to use the vaccination programme to sever that link between infection and severe hospitalization and severe effects and death of COVID. And the long-term vaccination plan is something that we need to keep considering. Are we aiming for that herd immunity? I think that's still a question mark. If we look at other pandemics that happen, like the flu pandemics and the seasonal flu, we're not aiming for herd immunity there, but we're aiming to protect our most vulnerable. So I think there are still some unanswered questions. Plus, again, immunologically, we don't know how this virus is going to adapt and interact with our immune systems differently. The vaccines look absolutely amazing, and the data that's coming out, and Adam said with the change in dosing schedule at the 12 weeks, the immune response looks much stronger, and so we hope that there will be longevity of that immunity. But there's a lot of immune questions that we need to answer before I think we can get to a place where we feel we can have a strategy to achieve herd immunity, if that's what we are aiming for.
Okay. Now we touched on the global picture, and let's spend just a few minutes on that, because after the G7, when they came up with a global COVID plan for 1 billion doses, and we had many people saying, look, it's 11 billion that's needed. This is a drop in the ocean. There have been claims of vaccine apartheid, moral failure. Dr. Gessner, you're with Pfizer now, but you worked for years with Gavi and the WHO. Do you have a sense of frustration that vaccines are not getting from rich countries to poorer countries fast enough?
Well, yeah. I can't imagine anybody who's involved in vaccinology and who's ever been in these countries wouldn't feel some frustration with them not being out there more quickly. I think that there has to be some appreciation of the normal context. So, or let's say historical context. So if you look before Gavi, which is, for those who don't know, it's the Global Alliance for Vaccines and Immunizations. So it's a way to pool money to purchase vaccines and to set up structures so that poor countries, the timeline between when rich countries use vaccine and poor countries use vaccine has been reduced. So it used to be, I think, in the neighborhood of 10 years between when a rich country had a vaccine and a poor country started using it. And with Gavi, that window initially got reduced, I think, down to around 3 years, and then has been getting ever shorter. And I think with COVID vaccines, it's going to be the shortest ever. So we shouldn't ignore the successes that we've had with the structures that have been developed, even if we're frustrated that it's not instantaneously available. But I think the other thing to keep in mind is there have to be mechanisms to get the vaccine out. So it's not like a company like Pfizer or Moderna can just take a bag full of 1 billion doses of vaccine and start distributing them in India or Nigeria or wherever. All of these countries have their own laws in place. They have their own import license. They have their own regulatory agencies. So all of those processes have to be respected, but they can be done quickly. And I think that's what people are trying to do, and to get production capacity up as high as possible. But yeah, I mean, going back to your original question, sure, I would like to have had everybody in the world vaccinated 6 months ago. So.
But Deborah King, when you saw that there was after the G7, the plan was for 1 billion, did you think that's great, or did you think, come on?
I mean, it is great. Every vaccine that's shared and is given to someone who's vulnerable and somebody who is at risk of serious illness, it's great. But I think I would say it needs to go faster. It needs to go faster, and I think where we have. I think in this country, have we committed to purchase something like enough for 6 doses for everybody in the country? I think we've committed to buying 300 or 400 million doses, which is far more than we need. And I think taking that global view on nobody is going to be safe until everybody is safe. And so sharing those vaccines with vulnerable people around the world before we look at vaccinating those who are unlikely to be substantially impacted by COVID seems to be the right choice in my mind. And however that can be done most quickly whilst respecting, I think, the overall complexity of the vaccine ecosystem, I think as Brad has already alluded to, the better that's going to be for everybody, because the longer there are places where there is uncontrolled viral replication, the more likely we are to see variants of concern arising that our current generations of vaccines are not able to control. So we put everybody at risk by not sharing the supply and reducing the risk to everybody.
Okay, and Professor Finn, I picked up from your answer to my question about children, you introduced the idea of the demand and the need globally. So I'm guessing you're thinking that there is a trade-off to be made.
Well, yes, and I think the other point I'd like to make is that it's not just a matter of doses. What I'm hearing from my regional advisor for the Euro region at the WHO is that there are a number of countries in our region who are receiving vaccine, as yet not very many doses, but some, but they are not efficiently able to deliver those doses to their populations. And so simply shipping vaccine around the world is only half of the solution. To get an effective program, you need vaccines in a good condition. You need a workforce that are trained to deliver the vaccines, and you need a population who can access and understand and show up and be immunized. And that's a big logistic challenge for many places. So I think we need to support those areas as well. It's not just a matter of shipping out our spare doses when we have them. We've really got to support those countries that need help to get the vaccines into the arms. Otherwise, the solution isn't a solution at all.
Can I just be clear which sort of countries you're talking about? Because you said in our region, which made me think you were talking about European countries.
Well, the WHO Euro region actually reaches as far as the Pacific. So it's a much bigger area of the world than the European Union. And it includes many of the countries, some of which are wealthy from oil, but some of which are not, of the former Soviet Union. So there are lower middle income countries, and there's one lower income country in a Euro region. And they're very variable in terms of their capacity to deliver vaccines. I think the problems in Western Europe are more heterogeneous and not so much an issue of infrastructure, although some Western European countries don't enjoy the centralized and highly well-organized health service that we do, for example, in this country, and also in Denmark and in Portugal, where they've got excellently centralized and well-organized delivery systems. So in some countries, it's quite fragmented, but the main problem is further east.
Now, it's such a vast subject, and I'm conscious of the time. So I do want to move on to something we touched on, which is, I set out at the beginning of young people, vaccines for toddlers and perhaps old people with flu. But, and it's come up already in our conversation that actually there is a sort of lifelong opportunity for people to have vaccines. Doug Brown, do we have a sort of the wrong attitude about vaccines in terms of how we're using them and when we're using them?
I don't think we have the wrong attitude. I think over decades of really successful research and development across the world, where researchers are coming together to develop these vaccines for different vaccine preventable diseases, they've delivered vaccines for these diseases, and they're being deployed in the very best way possible. One of the challenges, again, pre-pandemic, that we had been seeing in the UK in particular was that there was a decline in the uptake of childhood vaccinations, and we've touched on some of the issues around convenience and complacency with that. But I think we're very fortunate to have the vaccines we have. But where I think there is an opportunity, and we can learn from the pandemic over the last 15 months, is, well, what other diseases can we target with vaccines? What other are vaccine preventable? And there's nothing like wartime that promotes innovation and learnings, removing all of these barriers and hurdles that have been in place for R&D and for bringing these interventions through. So there are a lot of learnings from the pandemic that we can take to identify other diseases, maybe rarer diseases that weren't even on the radar for being vaccine preventable, for us to remove those barriers and have a global concerted effort to develop a whole host of new vaccines.
Well, what would you chip in then, that, you know, perhaps that as a result of COVID, that people are looking at as, look, can we deal with this? I know antimicrobial resistance was mentioned earlier. Do any of you have a sort of target that you think, look, this is the one we should really nail and could nail?
I mean, it's a good question, and I mean, the obvious ones would be infectious diseases, so pathogenic diseases. And there have been efforts in, say, HIV and in malaria, with some successes from a malaria perspective, hopefully, where the new potential vaccines are being delivered. But the main thing here is that we need to be thinking ambitiously about, well, which of these pathogens, or which of these diseases can we target with a vaccine type approach, if we're able to remove the barriers of funding, of working with regulators, of recruiting patients to trials, which have, you know, all gone swimmingly well for the pandemic. But colleagues on the panel may have a wish list of which ones to be targeting next.
Does anybody want to chip in?
Yeah, sure. So I mean, I think we're talking about moving beyond the developments have already occurred into teenage and adolescent vaccinations, and we're beginning to tackle sexually transmitted diseases now. And you're talking about the adult population before we get into the elderly. I think the obvious area of problem area is nosocomial infection, so infections acquired in hospital. This relates to the antimicrobial resistance point that you made. But it's a significant issue that when adults are admitted to hospital for something straightforward, there's a substantial risk that they will acquire an infection while they're there, which may even kill them, but might otherwise prolong their stay in hospital or result in complications. So I think there's a big open area for development of vaccines to try and reduce this problem of nosocomial infection. And that's one area, at least, that we should be thinking about. Thanks.
Okay. We're nearly up for time. I just want to ask each of you what you've learned as a result of the last 18 months, the pandemic, that perhaps is the most significant or surprising thing about vaccines and vaccination. Deborah, do you want to kick things off?
I mean, I think I said at the start, you know, I really think the speed with which vaccines were developed for COVID has been breathtaking, and I think we really have an opportunity right now to capture what it was, what innovations, what processes were challenged in terms of COVID vaccine development, and see how those could be applied to other vaccines in development. And I think, I mean, having worked, my background is working in HIV vaccine development, and despite decades of research, there's still no licensed vaccine for HIV. And similarly, when you look at a disease like TB, although we have BCG vaccine, it's not perfect, but it has a very high burden of disease. And so if we can capture some learnings from what was done for COVID and shift the overall ecosystem for vaccine development, we could see massive improvements in global health.
Doug Brown, what about you?
Well, if I may, two very quick ones. So completely agree with Deborah. The speed of research and removing those barriers has been incredible. I think an example of academia working with industry and with charities is this Centre of Excellence at the University of Bristol, working with Pfizer. Lots of really good examples of how groups of researchers and companies and universities and organizations have come together in a way never seen before across multiple different research areas. That's a momentum we absolutely need to continue. The other is, and we're not there yet, but I do feel that we're getting to a point in the UK where vaccination is starting to feel the social norm. And if we're able to develop this and keep this momentum going, that could help us for future pandemics, but also for other routine vaccination programs that we've talked about. You get the sense, you know, you can't avoid going on social media and seeing, you know, your friend, family member, colleague, taking the picture of them getting a needle in their arm or their certificate, and that, you know, there's a celebration when people are getting their vaccination, which, you know, someone who works in immunology and vaccinology, is wonderful. You know, it's a goosebumps moment. You know, for years my friends and family have not wanted to hear a single word about what I do, and now they're really interested. So if we're able to keep that momentum going, support people and allow people to celebrate vaccination, I think that can help us with a lot of vaccination programs going forwards.
Brad Gessner, what about you? I mean, because sitting inside Pfizer over the past year must have been extraordinary.
Yeah, I mean, I guess I would say that the mRNA technology may or may not, but I'm hoping it is, because it's such a quick technology, may be one of the great innovations that will be long lasting for many diseases. I mean, not just COVID, and it allows you to develop vaccines incredibly quickly. So that's one thing. I would say the speed with which, if people are motivated, we can have a vaccine from the disease is identified to the vaccine is being injected in people, and still follow every step of the pathway of safety and regulatory processes and get there in 9 months. I mean, I think that that's a fantastic learning, you know, I mean, and it bodes well for dealing with future pandemics. And then the last thing before letting Adam have a chance to speak is just that, you know, I think COVID and the global nature of this just emphasizes what Adam has said before, which is we're all dependent on each other for our health in these massive emergencies. And so vaccination, like I said, it's a social public compact, and it should be viewed as that, not as something you do just to protect yourself.
Adam Finn.
Well, only one thing from me. I've been doing vaccine trials, but nearly always in children for 30 years now. What's bowled me over and doing these adult studies over the last year is the amazing buy-in from members of the public who've come forward and volunteered to be in these trials. I announced on the local BBC in Bristol, the very first trial when we got going in March last year, we had 1,200 people call in 3 hours. And it's been like that ever since, right the way through to the studies we're doing now. People have just come forward And it's not because they wanted to get vaccines ahead of time. It's because they wanted to contribute to the effort to overcome the pandemic. And you know, my hat is taken off to those people. They are the real heroes of this story.
Professor Adam Finn, Dr. Doug Brown, Dr. Brad Gessner, and Dr. Deborah King. Thank you all very much for what I found an absolutely fascinating last hour, and I hope you have too, wherever you're watching. Thank you for all your questions. Some great questions. Hope you enjoyed it.